Alterations of hormonal regulation. Hormonal alterations can arise from multiple sources. Common causes include inappropriate hormone levels reaching target cells, malfunctioning endocrine glands, or failure in feedback systems. In some cases, hormones may be normal in amount but biologically inactive, or target cells may fail to respond due to receptor abnormalities. These disruptions can lead to complex clinical presentations depending on the hormone and tissue affected. Damage to the hypothalamic pituitary system can result from tumors, surgery, trauma, or vascular injury. For example, disruption of the pituitary stalk may prevent hypothalamic hormones from reaching the pituitary gland. This can lead to insufficient stimulation of hormone release from the anterior and posterior pituitary. Such dysfunction may result in widespread hormonal deficiencies affecting multiple organ systems. When hypothalamic hormones fail to reach the pituitary, hormone output from the pituitary gland is often reduced. This may impair growth, metabolism, reproductive function, and fluid balance. The specific clinical effects depend on which hormones are deficient. Early identification and hormone replacement are critical to restoring function. Syndrome of inappropriate antidiuretic hormone secretion, or SIADH, involves the excessive release of ADH. This can result from tumors, pulmonary or central nervous system disorders, surgery, or medications. The key consequence is water retention leading to hyponatremia, which can cause confusion, seizures, or even coma in severe cases. The severity of symptoms correlates with how quickly and how low sodium levels fall. In contrast to SIADH, diabetes insipidus is caused by ADH deficiency or resistance. There are two main types: neurogenic, where the brain fails to produce ADH, and nephrogenic, where the kidneys don't respond to it. Common symptoms include excessive urination, extreme thirst, and nighttime awakenings to urinate. Without treatment, patients risk dehydration and electrolyte imbalance. Hypopituitarism is the partial or complete loss of anterior pituitary hormone secretion. When all hormones are affected, the condition is called panhypopituitarism. It can result from pituitary infarction, tumors, trauma, infection, or autoimmune inflammation. The symptoms vary depending on which hormones are deficient, with cortisol insufficiency being especially dangerous. Hyperpituitarism occurs when the pituitary gland produces excess hormones, often due to a benign tumor known as a pituitary adenoma. Symptoms may result from either the mass effect of the tumor or the excess hormone itself. For example, a tumor producing prolactin can cause menstrual irregularities or infertility, while a growth hormone secreting tumor can lead to acromegaly. Overproduction of growth hormone leads to different outcomes depending on the age of onset. In children, it results in gigantism due to the continued growth of long bones before the epiphyseal plates close. In adults, it causes acromegaly, which presents as enlarged hands, feet, jaw, and facial features. This condition also contributes to insulin resistance and cardiovascular complications. This slide highlights two distinct outcomes of growth hormone excess: gigantism and acromegaly. On the left, we see a historical photograph of an individual with gigantism, marked by extreme height and bone overgrowth due to growth hormone hypersecretion during childhood, before the closure of growth plates. On the right is a patient with acromegaly, where growth hormone excess occurred in adulthood. Key physical signs include frontal bossing, prognathism or jaw protrusion, enlarged hands and feet, skin tags, and thickened facial features. Other features such as spade-like hands, papilledema, and bitemporal hemianopia indicate systemic effects and possible pituitary tumor compression. Both conditions require early diagnosis and treatment to prevent complications like diabetes, hypertension, and joint degeneration. A prolactinoma is a pituitary tumor that secretes excessive prolactin. In women, it causes menstrual irregularities, galactorrhea, facial hair growth, and bone density loss. In men, symptoms may include decreased libido, erectile dysfunction, and gynecomastia. Treatment often involves dopamine agonists to reduce prolactin levels and shrink the tumor. Thyroid disorders are categorized as either primary, due to dysfunction within the thyroid gland itself, or central, resulting from pituitary or hypothalamic dysfunction. In primary disorders, levels of thyroid hormone may be too high or too low despite normal TSH levels. Central disorders involve abnormal TSH production, which disrupts thyroid hormone regulation. Identifying the source of dysfunction is key to determining the appropriate treatment strategy. Thyrotoxicosis refers to any condition with elevated levels of thyroid hormone. When the cause is overactive thyroid tissue, it is called hypothyroidism. Primary causes include Graves' disease, toxic multinodular goiter, and solitary toxic adenomas. Central causes are less common and often involve pituitary adenomas producing excess TSH. Symptoms include increased metabolism, heat intolerance, and hypersensitivity to sympathetic stimulation. The most common cause of primary hypothyroidism is Graves' disease, an autoimmune disorder where antibodies stimulate the TSH receptor. This leads to unregulated overproduction of thyroid hormones. Associated findings include pertibial myxedema and sometimes exophthalmos or bulging eyes. Other conditions like toxic multinodular goiter and toxic adenoma also result in excess thyroid hormone production. Thyrotoxic crisis, or thyroid storm, is a rare but life-threatening escalation of hypothyroidism. This diagram illustrates the autoimmune pathway leading to Graves' disease and its resulting state of thyrotoxicosis. It begins with autoimmune activation, where the immune system produces thyroid-stimulating immunoglobulins. These antibodies mimic TSH and overstimulate the thyroid gland, leading to overproduction of T3 and T4 hormones. The thyroid gland may enlarge, forming a goiter. This hormone excess causes thyrotoxicosis, producing symptoms such as tremors, weight loss, flushing, increased heart rate, heat intolerance, amenorrhea, and heightened reflexes. In parallel, TSIs also contribute to ophthalmopathy and pertibial myxedema, leading to eye pain, visual disturbances, and characteristic skin changes. Normally, elevated thyroid hormone would suppress TSH via negative feedback, but in Graves' disease, this mechanism is overridden by antibody stimulation. This slide highlights two classic manifestations of Graves' disease, a form of autoimmune hypothyroidism. Image A shows a patient with exophthalmos, or bulging eyes, caused by immune-mediated inflammation and swelling in the tissues behind the eyeballs. This condition, also known as Graves' ophthalmopathy, is not just cosmetic. It can impair vision and eye movement. Image B displays pertibial myxedema, characterized by thickened, reddish patches on the skin over the shins. This occurs due to the accumulation of mucopolysaccharides in the dermis and is specific to Graves' disease. Together, these findings, along with elevated thyroid hormone levels, help confirm the diagnosis and distinguish it from other causes of hypothyroidism. Hypothyroidism results from insufficient production of thyroid hormone. In primary hypothyroidism, the thyroid gland itself is underactive, often due to autoimmune thyroiditis, thyroidectomy, medications, or iodine deficiency. In central hypothyroidism, Pituitary or hypothalamic dysfunction results in inadequate TSH stimulation. Symptoms include fatigue, weight gain, cold intolerance, dry skin, and slowed mental and physical activity. Common hypothyroid conditions include Hashimoto disease, an autoimmune condition that gradually destroys thyroid tissue. Congenital hypothyroidism occurs at birth and may result from thyroid agenesis or genetic enzyme defects. Subacute thyroiditis, also known as decurvain thyroiditis, typically follows a viral infection. Postpartum thyroiditis can develop in women after childbirth and may be temporary or progress to permanent hypothyroidism. This diagram outlines the typical pathway seen in autoimmune hypothyroidism, such as Hashimoto's thyroiditis. The process begins with autoimmune destruction of thyroid cells, reducing the gland's ability to produce T3 and T4 hormones. As thyroid hormone levels fall, the pituitary gland responds by increasing TSH secretion in an effort to stimulate the thyroid. Despite high TSH, hormone production remains low, and a goiter may develop due to chronic stimulation. This condition leads to hyperthyroidism, with hallmark symptoms like myxedema, fatigue, weight gain, cold intolerance, slowed heart rate, and impaired memory or mental clarity. This form of feedback is referred to as positive feedback, as the pituitary continues to increase TSH secretion in response to low thyroid hormone, despite the gland's inability to respond. The clinical signs of thyroid dysfunction reflect the hormone's influence on metabolism and cellular activity. Hypothyroidism leads to increased metabolism, weight loss, tachycardia, and heat intolerance. Hypothyroidism, on the other hand, causes fatigue, bradycardia, cold intolerance, and slowed reflexes. Skin, hair, ghee, and menstrual changes often accompany both conditions. Accurate diagnosis requires correlating symptoms with TSH and T3/T4 hormone levels. Thyroid carcinoma is the most common endocrine cancer. Its primary risk factor is ionizing radiation, especially during childhood. Most thyroid cancers are slow-growing and highly treatable. Management often includes thyroidectomy, radioactive iodine therapy, thyroid hormone suppression, and sometimes chemotherapy, depending on the tumor type and stage. Hyperparathyroidism is the overproduction of parathyroid hormone PTH, which increases calcium levels in the blood. In primary hyperparathyroidism, the gland itself is overactive. Secondary hyperparathyroidism results from chronic hypocalcemia, often due to kidney disease. Tertiary hyperparathyroidism occurs when PTH secretion continues even after calcium levels normalize. Hallmark signs include hypercalcemia, hypophosphatemia, and bone density loss. Hypoparathyroidism is a rare condition where the parathyroid glands produce insufficient PTH. It is most commonly caused by accidental removal or damage during thyroid surgery. The primary manifestation is hypocalcemia, which can cause muscle cramps, tetany, seizures, and cardiac rhythm disturbances. Lifelong calcium and vitamin D supplementation are typically required to maintain normal calcium levels. Diabetes mellitus is a group of metabolic disorders characterized by chronic hyperglycemia due to defects in insulin secretion, insulin action, or both. The major categories include type 1, type 2, and gestational diabetes, with additional genetic and secondary forms. Without adequate insulin, glucose cannot effectively enter cells, resulting in elevated blood sugar and cellular energy deficiency. Over time, this condition leads to significant vascular and neurological complications. Type 1 diabetes is the most common chronic disease in children and is divided into autoimmune and idiopathic types. In the autoimmune form, the immune system targets and destroys insulin-producing beta cells in the pancreas. By the time symptoms appear, 80 to 90% of beta cells may already be lost. This leads to a lifelong dependence on exogenous insulin and disruptions in glucose, fat, and protein metabolism. Both genetic predisposition and environmental factors, such as viral infections or dietary triggers, contribute to the onset of type 1 diabetes. Common symptoms include hyperglycemia, polydipsia, polyuria, and polyphagia, excessive thirst, urination, and hunger. Weight loss, fatigue, and recurrent infections are also common. If left untreated, this condition can progress rapidly to diabetic ketoacidosis. The hallmark of type 1 diabetes is a complete insulin deficiency, but other pancreatic hormones like amylin and glucagon are also affected. Glucagon levels may paradoxically rise despite hyperglycemia, worsening the imbalance. Amylin, which normally inhibits glucagon secretion and delays gastric emptying, is deficient as well. These combined effects make blood glucose regulation especially challenging in type 1 diabetes. The pathophysiology of type 1 diabetes involves autoimmune destruction of pancreatic beta cells by T lymphocytes. This leads to a progressive decline in insulin secretion, resulting in uncontrolled hepatic glucose production, lipolysis, and ketogenesis. Without insulin to facilitate glucose uptake, cells are starved for energy, and the body shifts to using fat for fuel, producing ketones as a byproduct. The result is metabolic acidosis and a high risk for diabetic ketoacidosis. Type 2 diabetes is characterized by insulin resistance and impaired insulin secretion, often driven by a combination of genetic and lifestyle factors. Risk factors include obesity, poor diet, inactivity, hypertension, and family history. Initially, insulin levels are elevated as the body compensates for resistance, but over time, beta cell dysfunction develops. This leads to relative insulin deficiency and chronic hyperglycemia. In early stages, many patients are asymptomatic. Later symptoms include fatigue, blurred vision, recurrent infections, and signs of peripheral neuropathy. Patients are often overweight, dyslipidemic, and hypertensive. Although ketoacidosis is rare, type 2 diabetes may result in a hyperosmolar hyperglycemic state. Management focuses on diet, physical activity, glucose monitoring, and pharmacologic interventions to improve insulin sensitivity and secretion. This diagram summarizes how genetic and environmental factors contribute to the development of type 2 diabetes mellitus. On the left, insulin resistance results from alterations in insulin receptors and signaling pathways, often driven by obesity and inflammation. This leads to higher insulin levels to maintain normoglycemia, also known as prediabetes. On the right, beta cell dysfunction leads to a progressive decline in insulin secretion. As beta cells fail, insulin production decreases and blood glucose rises, resulting in hyperglycemia. Over time, chronic hyperglycemia causes tissue damage and organ dysfunction, especially in the eyes, kidneys, nerves, and cardiovascular system. This diagram provides a comprehensive view of the systemic impact of chronic hyperglycemia, the hallmark of uncontrolled diabetes. On the top half, we see the causes, including insulin resistance, impaired insulin secretion, and metabolic dysfunction across multiple organs. In the pancreas, beta cells fail to release sufficient insulin. In muscle and adipose tissue, insulin resistance reduces glucose uptake. The liver and kidney contribute by increasing glucose production and reabsorption. In the brain, altered neurotransmitter signaling, and oxidative stress impair cognition. The digestive system and gastrointestinal hormones like GLP-1 are also disrupted. The bottom half reveals the consequences of prolonged hyperglycemia, ranging from retinopathy, nephropathy, and neuropathy to heart disease, stroke, and foot ulcers. Other complications include gastroparesis, fatty liver, hypertension, and increased risk of infection and cancer. Understanding these widespread effects underscores the importance of early diagnosis, tight glucose control, and comprehensive care in diabetes management. In addition to type 1 and type 2, other forms of diabetes include gestational diabetes, mellitus GDM, and maturity onset diabetes of the young MODY. GDM refers to glucose intolerance first identified during pregnancy and may increase the risk of developing type 2 diabetes later in life. MODY is a genetic form of diabetes involving mutations that impair beta cell function. Early diagnosis is crucial, as these types may respond differently to treatment. Diabetes can lead to several acute metabolic emergencies. These include hypoglycemia, which is dangerously low blood sugar, often triggered by too much insulin or missed meals. Diabetic ketoacidosis, or DKA, is most common in type 1 diabetes and involves ketone buildup from fat breakdown. Hyperosmolar hyperglycemic nonketotic syndrome, or HHNKS, occurs in type 2 diabetes and features severe dehydration and hyperglycemia without ketosis. In DKA, insulin deficiency leads to unchecked gluconeogenesis and lipolysis, producing ketones and causing metabolic acidosis. Patients present with rapid breathing, fruity-smelling breath, nausea, and altered mental status. In HHNKS, glucose levels can exceed 600 mg/dl with extreme dehydration and electrolyte imbalances, but no ketones. Both conditions require rapid fluid resuscitation, insulin therapy, and correction of electrolyte disturbances. Over time, chronic hyperglycemia damages blood vessels, nerves, and immune defenses. Microvascular complications include retinopathy, nephropathy, and neuropathies, which are major causes of blindness, kidney failure, and limb amputation. Macrovascular complications involve the large arteries and lead to cardiovascular disease, stroke, and peripheral vascular disease. Infections are also more common due to impaired immunity and poor wound healing. Diabetic retinopathy is the leading cause of blindness in working-age adults. High glucose levels damage retinal capillaries, causing microaneurysms, hemorrhages, and eventually new vessel formation that can lead to retinal detachment. Early stages may be asymptomatic, making regular eye exams critical for detection and intervention. Laser therapy, tight glucose control, and anti-VEGF injections can slow progression. Diabetic nephropathy is a major cause of end-stage renal disease. Chronic high glucose damages the glomeruli, leading to proteinuria, hypertension, and eventual kidney failure. Early signs include microalbuminuria, which may go unnoticed without screening. Tight control of blood sugar and blood pressure, along with ACE inhibitors or ARBs, can slow disease progression. Peripheral neuropathy and poor circulation in diabetes increase the risk of foot ulcers and infections. Patients often lose protective sensation, making them unaware of injuries. Wounds heal poorly, and infections may progress to bone, requiring amputation. Preventive care includes daily foot inspection, proper footwear, and prompt treatment of any skin injury. Disorders of the adrenal cortex include Cushing syndrome, hyperaldosteronism, congenital adrenal hyperplasia, and Addison disease. Cushing syndrome results from chronic cortisol excess, regardless of cause. Cushing disease, a subset, is specifically due to excess ACTH from the anterior pituitary. Symptoms include truncal obesity, moon face, buffalo hump, glucose intolerance, and muscle wasting. This image provides a visual of Cushing syndrome, emphasizing the characteristic body habitus. Patients present with central weight gain, facial rounding known as moon face, and a buffalo hump over the upper back. Skin may show thinning, bruising, and striae due to protein breakdown. These signs develop gradually and are often mistaken for general obesity unless carefully evaluated. Congenital adrenal hyperplasia results from enzyme deficiencies in cortisol production, most commonly 21-hydroxylase. The cortisol deficit triggers elevated ACTH, leading to adrenal gland hyperplasia and excess androgen production. Hyperaldosteronism is another adrenal cortex disorder. In primary hyperaldosteronism, or Conn syndrome, the adrenal gland secretes too much aldosterone, causing sodium retention, hypertension, and potassium loss. Secondary hyperaldosteronism stems from extra-adrenal stimuli like renal hypoperfusion or heart failure. Hypersecretion of adrenal androgens in females can lead to feminization, including breast enlargement and menstrual irregularities. Conversely, excess estrogens in males can cause viralization, or the appearance of male secondary sex characteristics like deep voice and increased body hair. These hormonal imbalances often result from adrenal tumors or congenital enzyme deficiencies, and they require thorough endocrine evaluation. Adrenocortical hypofunction, or hypocortisolism, includes Addison disease, which is primary adrenal insufficiency. It results from autoimmune destruction of the adrenal cortex, leading to low cortisol and often low aldosterone. Symptoms include hypotension, hyperpigmentation, fatigue, and electrolyte imbalances. In Addisonian crisis, the patient may go into vascular collapse and shock. This is a life-threatening emergency. Secondary hypocortisolism results from decreased ACTH production, often due to prolonged glucocorticoid therapy, causing adrenal atrophy. This slide contrasts the clinical features of two opposing adrenal disorders, Addison's disease and Cushing syndrome. On the left, Addison's disease reflects adrenal insufficiency, leading to low cortisol and aldosterone levels. Symptoms include hyperpigmentation, weight loss, muscle weakness, fatigue, low blood pressure, and abdominal pain. It may also cause personality changes and salt cravings due to sodium loss. On the right, Cushing syndrome is caused by excess cortisol, which may result from steroid therapy or a pituitary or adrenal tumor. Hallmark signs include central obesity, a moon face, buffalo hump, osteoporosis, muscle wasting in the limbs, and thin, fragile skin that bruises easily. Women may also develop facial hair and menstrual irregularities. This visual emphasizes the stark contrast between hormonal deficiency and excess, and the wide range of systemic effects each can produce. This slide compares Addison's disease and Cushing syndrome, highlighting their opposite hormonal patterns. Addison's features cortisol deficiency with weight loss, low blood pressure, and darkened skin. Cushing's reflects cortisol excess, with central obesity, elevated glucose, and skin changes. Accurate hormone testing and imaging studies help distinguish these disorders and guide appropriate treatment. Adrenal medulla hyperfunction is usually caused by pheochromocytomas, tumors originating from chromaffin cells. These tumors produce excess catecholamines, particularly norepinephrine, leading to symptoms like hypertension, tachycardia, headaches, sweating, and anxiety. Paragangliomas, similar tumors outside the adrenal medulla, can cause the same symptoms. Diagnosis often involves measuring plasma or urinary catecholamines and imaging studies.